Professor Hatem Elgamal of Gynecology and Obstetrics, and we shall discuss in this lecture the normal childbirth. We have previously discussed the two parts, and this is part 3 of the lectures. This slide represents the end of the second stage of labor. In the second stage of labor, we continue the assessment during the second stage of labor, and we give instructions and the active procedures and the subsequent continuous observation. Assessment, we revise our assessment during the second stage of labor regarding the general condition, uterine contractions, the fetal beats, and the vaginal examination, and the amniotic fluid, and the vaginal bleeding. In delivery, infection accounts for about 15% of all maternal deaths. These deaths can be avoided with infection prevention practices. Disposable materials, once and decontaminate reusable materials throughout labor and childbirth. Gloves during vaginal examination, during birth of the newborn, and when handling the placenta. Protective clothes, shoes, apron, and the glasses. Hands. Wash woman's perineum with soap and water and keep it clean. Ensure that surface on which the newborn is delivered is kept clean. High-level disinfected instruments, gauze, and the ties for cutting of the cord. Bearing down. Ask the patient to bear down with contractions and relax in between. Bearing down only after full cervical dilatation, when the mother feels the urge to bear down. Perineal support is very important. Support the perineum during contraction to keep the head flexed till crowning. Number 2, delivery of the head by extension slowly in between uterine contractions and sliding in the perineum over the face. Episiotomy. What is the episiotomy or perineotomy? It is a perineal incision right in the outlet. Episiotomy should be considered only in case of complicated vaginal delivery, scarring from the female genital, cutting or poorly healed 3rd and 4th degrees tears in fetal distress. However, schools consider episiotomy is essential in gravidas. Episiotomy or the perineotomy provide to perform its or the steps to perform the episiotomy. Number 1, you should provide emotional support for the mother. Make sure that there are no known allergies to lignocaine or related drugs if we do the episiotomy under local anesthesia and there is no regional anesthesia. We infiltrate beneath the vaginal mucosa, beneath the skin of the perineum, and deeply into the perineal muscles, about 10 centimeter or 10 ml of 0.5 lignocaine solution. Then wait to perform the episiotomy until the perineum is thinned out or until crowning is occurs, or 3 to 4 centimeters of the baby's head is visible during contraction. Performing an episiotomy will cause bleeding. It should not be done early before crowning of the head. Using high-level disinfectant gloves, place 2 fingers between the baby's head and the perineum. Use scissors to cut the perineum about 3 to 4 centimeters in the mediolateral direction. This in case of the mediolateral episiotomy. We have 3 types of the episiotomy: median episiotomy, mediolateral episiotomy, and the lateral episiotomy. And we will discuss the advantages and disadvantages of each type of episiotomy in face-to-face sessions. Control the baby's head and shoulders as they deliver, ensuring that the shoulders have rotated in the midline to prevent an extension of the episiotomy. Careful examination for the extensions and the other. In the period of episiotomy, it is important that absorbable sutures should be used. For example, the polyglycolic acid and the chromic catgut is also accepted. Follow the vaginal mucosa using continuous 2-0 sutures, and at the end, at the opening of the vagina, bring together the cut edges of the vagina. Bring the needle under the vaginal opening and out through the incision and tie. Close the perineal muscles using the interrupted 2-0 and closing the skin using 2-0 absorbable sutures. Essentials for the management of the newborn. For the management of the newborn, we should clean childbirth and cord care, initiation of the breathing and resuscitation, thermal protection, and the early and exclusive breastfeeding. Eye care, prevent and manage Ophthalmia Neonatorum, immunization, identification and management of the sick newborn, and the care of the preterm and low birth weight. Breathing initiation and resuscitation, spontaneous breathing. The breathing will be more than 30 per minute in most newborns. Gentle stimulation if at all. Of routine oronasal suctioning is unknown. Biological advantages, clear airway. Potentially real disadvantages, cardiac arrhythmia, and bulb suctioning preferred. Newborn resuscitation may be needed in cases of the fetal distress, thick meconium staining, vaginal breech delivery, and the preterm. Thermal protection is important. We should know the newborn physiology. Normal temperature of the newborn is about between 36.5 and 37.5. Hypothermia is considered when the temperature is below 36.5 degrees centigrade. Stabilization period in the first 6 to 12 hours after birth. Increased hypothermia occurs if the newborn left wet while waiting for delivery of the placenta. Number 2, early bathing of the newborn within first 24 hours. Hypothermia can be prevented if we deliver in a warm room. Dry newborn thoroughly and wrap in a dry, warm cloth. Keep out of draft and place on a warm surface. Give to the mother as soon as possible. Check warmth by feeling the newborn's feet every 15 minutes. Bath when the temperature is stable, nearly after 24 hours of birth. Take care to prevent or manage the Ophthalmia Neonatorum. Prophylaxis: clean the eyes immediately by 1% silver nitrate solution, not effective for chlamydia, or use 2.5 bovidine iodine solution or 1% tetracycline ointment. Assess of the Apgar score at 1 and 5 minutes. Score of 0, 1, or 2 for each of the 5 items. 8, 10 means the newborn is okay. What we record in the Apgar score: the heartbeat per minute, the respiratory effort, the color, the muscle tone, and the reflexes. Management of the third stage of labor, and this figure or this photo represents the shape of the placenta after delivery. Active management of third stage of labor for all women. We give them oxytocin administration, controlled cord traction, uterine massage after delivery of the placenta to keep the uterus contracted to minimize the bleeding. Routine examination of the placenta and the membranes. 22% of the maternal deaths caused by retained placenta. Routine examination of the vagina and the perineum for presence of lacerations or tears. Third stage of labor, it is the stage of delivery of the placenta. Complete delivery of the placenta and the membranes, prevention of the postpartum hemorrhage, and prevention of acute uterine inertia. What are the signs of the placental separation from the uterus? We have abdominal and vaginal signs. Abdominally, uterus becomes smaller and harder. The fundus rises upwards and become more globular with your suprapubic bulge. Vaginally, elongation of the cord, gush of the blood by the vagina, and loss of the transmitted pulsations. Delivery of the placenta. In delivery of the placenta, we have two methods. We have the conservative method, just wait for the expiration, and we have the active methods, the Brand Andrews method. Here, the fourth stage of labor. In fourth stage of labor, we observe the uterus is contracted. We're doing uterine massage to stimulate the contraction. Observe for vaginal bleeding. Observe the blood pressure, pulse, and temperature of the mother. Intravenous oxytocin drip is maintained during the fourth stage. Thank you.